Good afternoon, friends. Which laser to buy and why this topic? Because all you have witnessed for last 2 days that this is the real question in the mind of our all friends and colleagues, that which is the best laser available today and how you should decide that which is to be bought. So we have just tried to summarize various kinds of lasers. This is just RG Stone Urological Centers all over the country. We have 14 centers at the moment, and Dr. Bansal, who is sitting here, he has purchased 15 lasers. I think he is one of the greatest example that which laser to buy. He has done all the infrastructural work, and this slide itself shows you that we all being urologists, we don't have time to think about which one to buy, but he has all the time in the world to think about which laser to buy. And this simply represents that anybody who can buy 14 lasers in the country, the decision was difficult, but once he has decided, means he is a real person, the leader who can be followed, and the decision is not difficult. But still, we have to scientifically analyze that what we are willing to see in a laser, what we want to do, what kind of workload we have in our center. There are so many laser machines in the market, and the market is flooded with thulium laser, the diode lasers, the holmium laser, and earlier it was Nd:YAG laser. In 1995, the first laser which we started with was Nd:YAG laser, and that gave a very bad name to lasers in the sense that it used to coagulate the tissue used to get necrosed, and then it used to keep sloughing for a period of 4-6 weeks. Some patients had to be kept on catheter for a long period, and those days fortunately have gone with the advent of newer lasers. And I think that we have the history. You all know that what is this laser, light amplification by stimulated emission of radiation, and this theory was initially given by the Einstein quantum theory. And since then we have seen the lasers evolve. We have now then it was the Ruby laser. First urologist was the Parson to experiment with laser light in canine bladders, and then we had Mulwani who did in 1968 the laser lithotripsy, and since then we had Nd:YAG laser 1993, and with this we were doing visual laser ablation of the prostate. Now the diode laser initially was introduced for interstitial laser coagulation, and this was initiated by Muster and Hofstetter. This interstitial laser coagulation also did not stand the test of time, and patients had lot of, basically the problem was that whenever the lasers were used initially, these patients had one issue of residual prostate, and the other issue was of recurrent urinary tract infection after treatment. Patients used to get recurrent urinary retentions, and some patients to the tune of 30% had to undergo a TURP after 1 year, 2 years, or even 3 years or later. So what are we expected out of laser is that if you have done something, patient should not come to you again and again for the residual tissue. And that is the aim, and with that aim it was Sir Peter Gilling who initially worked with holmium laser, but the holmium laser has also evolved over a period of time. Initially it was ablation with holmium, but then the enucleation, once enucleation came, it has revolutionized the history. Enucleation means we can do an endoscopic open prostatectomy, equivalent to endoscopic equivalent to of open prostatectomy, and this you can have a complete enucleation, no redo cases, means even up to 10 years there is no need that one has to go again. We have newer lasers like KTP laser, but it is good for patients who are on anticoagulants. It is good for patients who want treatment under local anesthesia, but the issue of residual prostate, recurrent urinary tract infections, the posterior blood, this urethral synecdoche formation, and I must confess to you that today we are a center of laser prostatectomy, and we are getting lot of patients who have had KTP laser done earlier, and they come to us either with retention, recurrent UTIs, residual prostates or hematuриas. So therefore, in the last 5 years, we have done around 15 cases post KTP problems. So maybe in some forum I will show you this data that post KTP, these lasers, these patients don't do as well as they do after holmium enucleation of the prostate. So friends, lasers are evolving, and I think we have now another laser called biolytic laser, the thulium laser, and I will just tell you what are the plus and minus of these lasers. And this is just to show you the lasers, they differ in their wavelengths. The wavelength, KTP has a 532 nanometer wavelength, and the lesser the wavelength, the more the absorption by hemoglobin. If you have higher wavelength, say 2000, it is more absorbed by water. So the advantage is that if you have a laser like holmium or thulium, it is more precise knife and the absorption is minimal. So there is no fear. It cuts what you cut, what you see, what you get. So that kind of effect is available with holmium. That is the beauty, that you are holding a knife, and then when you cut, you are cutting only as much as you are seeing. So that is the advantage of holmium laser compared to the KTP laser, that you are applying some energy and you are getting effect around 8 millimeter deeper or 4 millimeter deeper. So therefore, there is absolutely no risk if you have a precise knife in your hand, and that precise knife is the holmium or the thulium. So this is what is exemplified what I said, that the depth of penetration is very important. There are urologists who are very much scared using KTP because it may do some inadvertent damage because of the depth of penetration. But if you have the holmium, 0.4 millimeter is the depth of holmium. So the depth is so less that it is just like a precise knife. And so what we find that there are two basic, one is vaporization and the other one is the enucleation lasers. So the vaporization lasers means that it is absorbed by hemoglobin, and when it is absorbed by hemoglobin, when you apply it to the tissue surface, the tissue gets vaporized. And enucleation techniques are very difficult to master compared to the vaporization, which is very easy to learn. However, when you are doing vaporization, you have to spend lot of time. Initially the tissue which is rich in hemoglobin gets vaporized faster, and therefore if you have the evolution of these kind of vaporization lasers, you will find initially they came up with a 80 watt laser, then they came it with 120 watt laser, then now in this Chicago conference I saw 180 watt KTP laser. So that means that this phenomena of improving KTP is also going on, and they want to achieve better and better with this vaporization. Now why so much talk about these lasers is basically that lasers have made the life not only of the patient but also of the surgeon, the nurses and the whole team very comfortable. So the life of the whole team has become so much comfortable that whenever we were doing TURPs, the procedure had to be finished in say 60 to 90 minutes. So there were a lot of sympathetic overactivity, and the point was that the surgeon, and not only the surgeon, even the anesthetist used to be under a lot of tension. And today I must confess that our anesthetist sits in the side room, always busy with the newspaper or the coffee, and he has plenty of time to relax because there is absolutely no tension when the surgery is going on. So the life of the surgeon and life of the anesthetist is also important. Today the corporate sector is there, and we want to see that our friends, colleagues, they should live longer to serve the society for a good long period of time. So that is the thing which lasers have done for the whole community. And that is why I think that we all should buy a laser, to not only to deliver goods to the patients, but to deliver good quality of relaxed life to ourselves. This is just to tell you the same thing, that no blood transfusions, negligible nursing events. So practically we have not given blood transfusions to nearly, now I have done 3000 cases, and we don't have to think of blood transfusion. So this is what has made the life very simple, and that is, this revolution is catching up, and we have from all south, north, east, west, all over the places, large number of cities, initially A grade cities and now B and then C grade cities are also catching up to buy lasers. The reason for this is that the cost is also coming down, the awareness is coming up, and the most important thing which I feel is the quality of results, the durability of results and the quality of results which we are achieving or getting with the enucleation procedures is really making all of us to think in terms of buying a laser. And this is just, I said that the KTP, this Nd:YAG laser was disappointing outcomes due to biophysical properties of this wavelength. And as I told you that this holmium, it's a pulsed laser, and I am asked every day this question, that how holmium differs from thulium. The beauty of this holmium laser is that it is pulsed. Now what is the meaning of this pulsed? Everybody tells that it vibrates. So if it vibrates, it's definitely, you have to really spend some time learning that a vibrating fiber, how to focus your eyes with a vibrating fiber. But the point is, once you master this, you will be able to give a very precise cut, and this pulsed laser gives you very intermittency, means the thermal energy or the heat generated by the laser energy is also limited. With thulium, there are more chances of the heat getting diffused, and I have witnessed Dr. Watson and many others, when they do thulium, sometimes they have to put in a suprapubic cystostomy, they have to reduce the this thing, and the loss to the telescopes. When you have very high energy being given, continuous mode, the telescopes also can get lost. So therefore, this pulsed energy, the other advantage of this pulsed energy is that the anatomy. With thulium, you don't have such a clear-cut depiction of energy, but with holmium, the anatomy is as you find in textbooks. So therefore, I would say that with holmium and laser, you have a better delineation and depiction of anatomy. You can see the capsule fibers just as clear as you would like to see in the book picture. And the another thing is, when you have this pulsed energy, there is a vapor bubble at the front of the fiber. Initially there is a photomechanical effect tearing the tissue apart, followed by tissue vaporization. So once Dr. Kotwal was seeing how he was operating, and he said, Anil, it appears that you are working with driving a motorcycle in snow-filled mountains. So this is something that if your eye is not set, you will have that kind of effect. But later on, once you get confidence, you will find that this gives you a very clear-cut anatomical description. And I think that credit of all this goes to Sir Peter Gilling, who initially described this bladder neck incisions, ablation, and then resection and enucleation. So evolution, as I said, that holmium has evolved over a period of time. This is the holmium equipment. And Sir Mustafa M. Ali Hali, who is the president of Society International Urology, has published already that it should be considered as a new gold standard. The new gold standard, just because that why TURP is a gold standard, that it gives you efficacy. Same efficacy is available with this, and at the same time it is much less morbid than the TURP. Today we have large number of randomized controlled trials. The literature is full of them, and I think Hemendra Shah, who is sitting here, has also contributed a lot to that literature, proving the point that holmium can give you good enucleation, significant reduction in prostate volume, much better than TURP. If TURP can give you a prostate volume reduction up to the range of 50 to 60%, the holmium laser can give you a reduction up to 70, 80 or even 90%. So the tissue removed with holmium is much more than with the TURP, KTP, or for that matter any other laser. and one can achieve the efficiency of enucleation up to 3 grams per minute, efficiency of morcellation up to 10 grams per minute, and therefore the speed of enucleation, the overall speed of HOLEP you can really achieve once you master this technique. Complication rates are very limited in the sense that they are no different than that of TURP, and the long term PSA reduction is the proof that this laser is very effective. And as I said that when we talk about, there is lot of talk going on in the market. Every day newspaper you open and you find a flyer of KTP laser. Now what is this about? As I said, that because it is absorbed by hemoglobin, there is a small optical penetration depth in the tissue, confinement of energy to a superficial layer of prostatic tissue that is vaporized hemostatically within a 1 to 2 mm rim of coagulation. So initially, as I said, we had 60, then 80, then 120, and now 180 watt, but still the evolution is going on. And this is the equipment. It can be done as a day care procedure. It, as I said, the cost is a major issue with this. The fiber, one fiber costs you around 40 to 50,000 of rupees, and with one fiber at the best you can do 2 cases, and those 2 cases have to be done in the same day. There is some problem with the computerized chip which is there in this laser, which does not permit you, and therefore patient has to give you at least 1.5 to 2 lakhs of rupees for one procedure. So I don't know that how many Indian patients can be helped with this kind of laser, because it is costly, though it is claimed to be effective for prostates of any size. But as the size of the prostate grows, the KTP efficiency becomes less, time taken becomes more. I have seen in the literature, it is published that the large gland which was taken up, the operator spent 3 to 4 fibers, and the time period was up to 7 hours. So you are spending 7 hours to vaporize around I think 100 gram gland or so. So those are the issues with this laser, but there are a lot of randomized controlled publications with KTP also, and as we have increased the power of KTP, the efficiency of enucleation has improved. This was an earlier paper which showed 0.3 to 0.5 gram, but people are now claiming 1 to 2 grams per minute. But the major problem with this is the prostate volume reduction. It is a very busy slide. I am sorry you won't be able to read, but in summary I would like to say that the PSA reduction is very less, 34%, 42%, 37%, which proves a point that it is at 1 month after the KTP laser and then 12 months post operatively. So even after 12 months means that was the time when there is no inflammation. So PSA has not come down, and only reduction is 34%. The tissue prostate volume reduction is also to the tune of 30, 40%, 50%. So this is something very serious with KTP, that the prostate volume reduction is less, the prostate PSA reduction is less. Patients do get recurrent urinary tract infections, although the other complications like incontinence, stricture rates, and bladder neck contracture rates, they are less to the tune of up to 1%, but the serious issue is the residual prostates, recurrent urinary infections, and therefore one has to think twice before putting his money into KTP laser. And now lot of, when you roam around the stalls, you will find that these people are conversing you for thulium laser. What is this thulium laser? Thulium basically, it is like similar wavelength as that of holmium, but it is a continuous wave laser, and tissue effect restricted to less than 1 mm beneath the cut and produces excessive charring. Now this is something that I have seen the experts doing this thulium. You find the tissue charred. So the anatomical clarity which we expect from a laser or for any surgical procedure is not there with thulium. Visibility of course is not impaired by excessive bubble formation, tissue fragments, ruptured tissue, visible laser radiation or coloring laser shields. Endoscope lenses remain clear, so it is faster. That is the only beauty that it is faster. But let me tell you friends, that if you master the technique of Holmium enucleations, you will understand that you can do it very fast. So the issue of doing faster, of course, when you use thulium, it's very fast. You cut it like butter. So the prostate, but it can be done very fast. But again, the technique of enucleation has to be mastered, and the long-term data is awaited. But the Andreas Gross group at Germany has made an effort, because there is loss of discrepancy in data presentation and collection, because somebody is doing vaporization with thulium, somebody else is doing enucleation with thulium, another one is doing resection with thulium. So we have made these kind of study groups, so that Thu-VAP is compared with Thu-VAP, Thu-VARP is compared with Thu-VARP, enucleation is compared with enucleation, like that. So that the discrepancy, because today if you see somebody presents a data, it is of ablation, some other fellow presents the data of enucleation, and there is lot of mixing. So to avoid all that mixing, the World Laser Association has thought of giving clear cut this nomenclature, so that the presentation long term data is not sort of misguiding the reader. Similarly, we have got another laser which is available, which is cheap, economical and cost effective, which is a biolytic laser. It is a diode laser. They have also sort of improved further and made I think the latest peak power of 300 watts is available with this laser. The wavelength is 980 nanometer. It provides the highest combined absorption in water and hemoglobin. So this laser has the benefit of both. It is moderately absorbed in water, moderately absorbed in hemoglobin. It causes excellent vaporization and hemostasis, and shortens the treatment time. So I am sure that now lot of people have purchased this biolytic laser, and it is a group in Chennai. 18 urologists have joined hands to buy this biolytic, and they are doing it. Only thing is that with this laser, again the problem is that of fiber, that with Holmium, with one fiber you can do say 100 cases, 40 cases, till the fiber lasts. But here again we have a chip, so that with one fiber either you can do 2 cases, or I think Dr. Anil Goyal is sitting here, he will tell you how many cases he has done. He has done 5 cases with one fiber. Yeah, so that is the maximum which you can do. With one fiber you can do 5 cases. So but we have done up to 200 cases with one fiber. So that is the cost. So ultimately, as yesterday I was telling you, that when we buy a laser, we have to think in the terms of maintenance contract as well as running costs. So running costs ultimately comes down to the minimum with this kind of laser. And of course, the treatment time, once you master the technique, it becomes less. And I think we all have seen these slides, and Dr. Pankaj is going to tell you more about this learning curve, which has been time and again highlighted. And it is we all have learned various procedures like laparoscopy and whatnot. So I think that learning curve should not be taken as a discouragement. It should be mastered, and whenever we we want to master, we have to have some guidelines, and the guideline is that first 10 cases you should do glands less than 40 grams. If you take up a 100-gram gland in the beginning, there will be disaster, and once the technique is mastered, then larger glands make sense, and potential problems can be avoided altogether or easily addressed. So therefore, one has to learn that what kind of problems. There is always a temptation in the beginning to convert to TURP, but if you want to really learn how to do a good enucleation, that temptation should be resisted, and then only one can master these things. And of course, the one advantage which I personally feel is a real advantage, that is the various permutation combinations of these energy settings. You can have sort of variations up to the rate up to 50. So from 0 to 50 is the permutation available with rate. So at every permutation combination there is a different effect. Some permutation combinations are good for vaporization, some are good for cutting, some are good for this apical dissection, some are good for coagulation. So therefore, it is very important that we learn this statistical and the mathematical jugglery to get the best effect that we want with the particular situation. And I think this is some of the cases which we have done with post URP, and this is I presented in Cape Town, that now practically for last 5 years I have not done a case which is 3 lobe, classical 3 lobe. Here you can see this is the right lobe and the middle lobe is getting lifted up, right and middle together. So this is the beauty of 2 lobe technique. One does not have to do the third lobe, this median and 2 lobes separately. You can do this 2 lobes as a whole. So that is very important, and the kind of fossa you get. Now this is the kind of fossa one gets after holmium enucleation. That is something as one has done the open prostatectomy. Virtually there is no tissue left. You can just see the sphincter, some of the fibers hanging at the top, but if you see the viru which is just here, and so much of apical tissue which has sort of got lifted with the enucleation. So if you have done a good enucleation, means nothing would be here, and therefore these patients have a good urodynamic results post operatively, because there is absolutely no prostate left. And therefore, if we see that I think I have already highlighted these things. To summarize, the procedure is very effective when we do it with holmium. It is urodynamically superior, it is durable. I presented this 10-year data at Chicago that we have now, and the PSA and the truss volumes, they are the ones which tell us that how effective is this holmium enucleation, and these are the publications by our group also. And the other thing, when we buy a laser, we are thinking not only of prostate. If majority of us has lot of stone work, we have strictures, we have this bladder tumors, like that. So when we can do for prostate of any size, it has extremely low recurring costs. All types of stones can be treated with holmium. It does an excellent job for strictures and tumors, and we have done lot of simultaneous bladder stones and the ureteric stones and PCNL along with HOLEP, and we can also use it in arthroscopy, spinal discectomy, gynecology, ENT and laparoscopy. Therefore, a hospital which has got all the branches can also use holmium for different specialty uses. And I think we have already talked about limitations. And when we are thinking about buying a laser, the international debate today is whether you buy a vaporizing laser or a laser which can enucleate. And I think, to my mind, the best thing whenever such a debate comes to you is that what are we doing laser for? We are doing laser for patient satisfaction and long term durability of the procedure. So therefore, in anybody's mind, the ultimate goal is that if you have done laser prostatectomy, patient should not come to you again for any kind of problem. And therefore, consensus is now shifting. Initially, this vaporization laser was holding the grounds for a long time. The reason was it has a short learning curve. You buy a laser, you can learn this laser very fast, but as the long term results are coming up, this tilt or the balance is shifting in favor of enucleation, and that is the thing, that it is cheaper, effective and safe. And therefore, when we think of enucleation versus vaporization, only disadvantage when we enucleate is the additional cost of morcellator. But I think that morcellator, we have got lot of alternatives, and no tissue is available following vaporization is one issue. With the enucleation, whole tissue is available and for good histopathology. And when we think about long term results, when we compare these changes following HOLEP, following TURP and green light, this is something I think my friends will also discuss about it, that the best percentage reduction is with HOLEP compared to TURP or green light. And therefore, when we have to think in the large prostates, I think nothing can beat holmium enucleations. Very large glands which in the past would require staged TURP or open simple prostatectomy can now be treated with HOLEP. Patients with large glands still have minimal hospital stays and catheter times. So, if you compare the complications, you will find that dysuria is definitely much more with the vaporization lasers compared to enucleation lasers. Rate of UTI is more with vaporization lasers compared to enucleation lasers, and similarly the bladder neck contracture is much less with the enucleation compared to vaporization. And I think we have shown, this is our experience. Largest gland we have enucleated is 276 grams. Various kind of high risk cases, patients on pacemakers, patients with poor ejection fractions, patients with CRF, all can be dealt with. And the large glands, as I said, we have done 316 glands more than 100 grams, 28 glands more than 200 grams. So, and we had not to use blood except for 1.3% of the overall, and that too in the patients of more than 100 gram group. And therefore, that is where the beauty of this holmium laser, and I think we all get stimulated by the work, these kind of data, that we must learn the procedure. And the area is again that this is an actively bleeding large gland. This was 218 gram gland, and when we took this patient for open prostatectomy, but our anesthetist told us that patient appears stable, you try enucleation. The moment we went beneath the median lobe, the bleeding disappeared completely. So therefore, because it is a vessel first approach, I am sure you all understand that if we would have, we cannot do TURP in a case like this. So, and this is how we feel gratified, our patients feel happy when you remove such amount of tissue, when you have done a 218 gram gland, and the time taken 80 minutes. I think yesterday Dr. Pankaj was telling you that Hemendra has already published this paper, that larger the gland, lesser the time. So that is in contrast to vaporization lasers. When you have larger gland, you take more time, but when you have enucleation, you have a large gland, relatively you take less time. And therefore, satisfaction not only to the patient, to the surgeon also. See kind of flows, we have seen peak flows of 54, 60, this kind of flows following holmium enucleations. And the histopathology is no charring or nothing. And the post void, this patient had a pre-void, pre-operative PVR of 1280 ml, and I was debating whether he will void post-operatively or not with a PVR of 1280. And you will be, I was gratified when I found post-operatively his PVR is 10 ml. So such a bag-like bladder with 1280 ml of PVR, but this is where this holmium enucleation scores over any other thing. 6 months later, if you see such a patient, you will find hardly 12, from 218, this is 12 ml prostate, PSA 0.48. So this is drastic reduction in PSA, thrust volumes, and this is a data up to 10 years with 1143 cases. And I think we are very happy to note, and the foreigners are always interested in knowing about loss of potency. And the beauty of this laser here also is that the loss of potency is not there. It is 2% in cases where the pre-operative you have good potency, the reduction is not there. So we have to think in various ways when we are, and therefore I would like to conclude that laser, when we think of lasers, the two most mature techniques are holmium enucleation and KTP. The laser vaporization of the prostate are most mature techniques, and they are presently giving a genuine challenge to TURP and open prostatectomy. Despite favorable hemostatic properties of various diode lasers, a higher invasion depth seems to result in necrosis of the tissue, leading to a higher rate of reoperation. And this was published in World Journal of Urology 2010, that thulium laser results seem promising, but data is limited. So friends, that there are disadvantages of laser, and I think all of you would agree that there is a high initial cost, recurring cost, steep learning curve, significant endoscopic skills are required, and duration of surgery is more than that is under, in my hands it is less than TURP, but the other issues are they can be dealt with. Recurring costs are minimum with holmium, and therefore only drawback of a holmium is that you have a high initial cost. So if you are ready to raise the bar of this high initial cost, and therefore now it is I am impressed to note that there are Indian lasers and Indian morcellators. People are catching up. For last 11 or 12 years that we have worked, now it is the whole industry is stimulated to make an Indian laser, and I think this is the future direction that we have to think in terms of a suitable laser for a given clinical situation for optimal outcomes. One laser for everything, maybe that day will come that we will have 2 lasers at our center, one laser for a specific situation. Economical and sturdy is the ultimate goal, and I think the industry is working in that direction. Short learning curve comes from the mentor training programs, and I am proud to say that Luminis India has recognized 2 centers in the country, one in New Delhi and one in Mumbai, to train urologists not only from India, for whole of Southeast Asia as well as all over the world. And all the panelists are the faculty members for that training program, and we are looking for a better morcellator and a cheaper morcellator which is going to reduce the cost. We are going to have these recognized training centers all over the world. It is not going to be restricted to few centers. Many a times I am told that there are only 5-6 people in the world who are doing holmium. So Anil, what is the future? I think that we have changed the future in the sense that even in India today we have more than 50 people who are doing holmium enucleations, and in next conference you will find 100 people doing these cases very well. So the economic issues are very, very complex. Only thing is that all this what I have told you is the basis for selection, that how you buy a laser, but our data have demonstrated that HOLEP is associated with significant hospital net cost savings, and this compared to open prostatectomy also, and therefore patients undergoing surgery for symptomatic BPH for large glands, HOLEP has proved to be a cost effective procedure, and high early morbidity of TURP one never thinks, and therefore if you calculate all the factors you will find that buying a holmium machine is good for the hospital as well as for the patient. So when we do this cost analysis, we have to think in terms of not only the cost of the machine, cost of consumables, AMCs, dedicated technicians, endoscopic equipment, and the kind of fluids which we use, quantum of workload, type of cases, because it is very important. In India we have more of stone cases. So if we are thinking in terms of buying a laser, we should not, if a person is doing only stone cases, a 20-watt laser is good enough. But if you have a more than 200 prostates per annum, you need to buy a laser like 100 watt which can take care. So therefore when we have to decide on KTP, diode and thulium, they are prostate only lasers. When we do anything else with a diode laser, the fiber breaks. If the stone comes in a patient of prostatic calculi, if you want to enucleate with a diode, stone comes, you have problems. Similarly, so the holmium is the only laser out of all available lasers which is good enough for situations like stones, and I think in India we have lot of stones. So therefore one has to take decisions, and therefore I conclude that holmium laser is an effective technique for treating obstructive prostates of any size. The safety profile permits it to be done with severe comorbidities, and the hemostatic capability and reusability of the fibers make the procedure cost effective and affordable in Indian scenario, and undoubtedly a 100-watt holmium laser, I have no doubt in saying that it is the best equipment to invest in. Thank you. This is just our training programs which we are running all over the countries like Indonesia, China, Bangladesh. Urologists are coming to our center, and these are dedicated live demonstrations, dedicated lectures, and this is going on, and I invite you all to our center, witness how we do. We are doing practically every day 2 to 3 HOLEPs, and any day you are all welcome to attend and see how we do it. Thank you.